Hello everyone, this is Dr. Upasana and I welcome you all to another series of RRR's YouTube series for Part 2 MRCOG, and today we'll be covering the topic of oncology. As many of you know, I'm a mentor at Study MRCOG and I'm a gynecologic oncologist. Let us start with a quote that time is non-refundable, so please spend it wisely. Each and every minute actually counts, and we are able to realize that more so before the exams. So today we'll be discussing regarding cervical cancer screening, cervical cancer in pregnancy, FIGO staging of endometrial cancer, management of endometrial cancer, FIGO staging of ovarian cancer, management of ovarian cancer. So let's start with the cervical cancer screening program, for which you need to follow the NHS protocol. And please remember, from this topic, every year you will definitely get a question, either one EMQ, 1 or 2 EMQ, or maybe more. Okay, it may be so that you may get 2 sets of EMQ, that is 3 and 3 questions each. And plus the SBAs are also very important. They are frequently asked from this topic. So this is a must-do topic from oncology. So first we'll go through this topic. So these are the options, and you need to select the single most appropriate intervention from the list. Let us go through the first question. So a 27-year-old para 2 woman has a routine cervical smear test, has high risk HPV positive with a cytology result showing low grade dyskaryosis. So her high risk HPV, her HPV test was positive. So definitely, you know that if a HPV test is positive, then we need to do a cytology. So now the cytology result shows low grade dyskaryosis. Colposcopy is done. It is adequate but normal. So what will be your next step now? So you will be able to easily answer this question in case you have a good idea regarding the flow charts that are mentioned in the NHS guidelines. So let us just go through in brief regarding the cervical cancer screening pathway as per the NHS. So they have divided the entire pathway into 3 parts. The first is the invitation for screening, sample taking and HPV testing and cytology triage. The second is the colposcopy. Third is what you need to or how you need to manage in case of abnormal colposcopy. So these are the third parts of the cervical cancer screening pathway as per the UK guidelines. Now, this is the first part. So we all know that the primary screening test for cervical cancer is now HPV testing. So HPV testing, when you are doing an HPV testing for an individual, it can either come out to be negative or positive. If it is negative, you go for a routine recall, that is again after 3 years, and in case it is positive, then you need to go for a cytology. So cytology can be now abnormal or it can be negative. In case both are abnormal, that is HPV is positive, cytology is abnormal, so both are abnormal, then you need to go for a colposcopy. However, if the cytology is negative, then you can wait and you can repeat a HPV testing at 12 months. However, if the HPV testing at 24 months, that is 2 consecutive HPV testing, if they are testing positive, then irrespective of the cytology, even if the cytology is negative, you need to go for a colposcopy. Okay. So if we go to the second part of the question, a 30-year-old woman attends for a routine smear test, having previously had normal smears. She has 2 children and has been sterilized. Her smear test was positive for high-risk HPV and cytology shows high-grade dyskaryosis. So here you can appreciate that here the keywords. So whenever you're doing an EMQ, start identifying the keywords. Then it is very easy to attempt the question. Okay, so that in that way you will be able to save time and you will not be able to you will not confuse yourself in EMQ. So always first start marking the question, search for the keywords, and then frame the answer in your mind, and after that search for the answer in the options given, and then look for just rule out the other options. This is how we used to do while we appeared for our part 2 MRCOG. So this is a tip, a small tip which I would like to share with you guys. So here you can see that HPV is positive, cytology is high grade dyskaryosis. So as we saw in the first part of the flow chart, so here the answer will be colposcopy. So this is obvious that 2 abnormal, that means you have to go for a colposcopy. So that thing you know. Now you need to decide whether it is 2 weeks or 6 weeks. So here, because it is high grade dyskaryosis, that means you have a very high suspicion of cancer, so you cannot wait. So the answer will be B, that is colposcopy within 2 weeks. Okay, so this is how you need to rule out the other options, because if you see colposcopy, colposcopy is an option in B and C both. Both the options are colposcopy. So B will be greater than C. Answer is B. Now coming to the second part of the screening. So here, now you have done a colposcopy. Now the colposcopy can be either adequate or it can be inadequate. In case the colposcopy is adequate, then you need to see that what did the examination show. In case it is an abnormal colposcopy, then the management will be dealt with in part 3. In case there is no colposcopic impression of CIN or there is no CIN or biopsy, then you need to go back and see what was the result of the high risk HPV and cytology test. In case it is high risk HPV positive and the cytology is also high grade or borderline or endocervical, then you cannot let go of this individual. You need to discuss it with the MDT within 2 months, that what you need to do, because though the colposcopy examination has come out to be normal, but still she is at a high risk of having cervical cancer. So you need to discuss her case at the MDT. Now, if the high risk HPV is positive or the cytology is less than equal to low grade, then you can safely recall her in 36 months. In case the second consecutive high risk HPV is unavailable or the high risk HPV is positive or cytology is inadequate, then you need to recall her in 12 months. Now coming to when the colposcopy is not adequate. In case you were unable to do an adequate colposcopy, then again you have to go back and look at the result of the high risk HPV and cytology tests. Now in case the high risk HPV is positive and the cytology is less than equal to low grade, then you need to repeat the colposcopy again in 12 months. Now, however, if the high risk HPV is positive and the cytology is greater than equal to high grade or borderline, that means both the things are abnormal. However, your colposcopy you have done, it was not adequate, then you need to undertake a LETS procedure. You cannot let the women go. You have to do something for the women. So you need to undergo a LETS procedure. So if we look at the first question, a 27-year-old para 2 woman has a routine cervical smear test, has high risk HPV positive, but the cytology shows low grade dyskaryosis. Colposcopy is done, is adequate but normal. So here the colposcopy was adequate and normal, so it will fall under this. Now the high risk HPV was positive and the cytology is low grade, so you need to recall her in 36 months. So the answer here, if we now go back to the options, so the answer will be K, that is repeat the smear in 3 years. Okay, so I hope this is clear. Now let us go through the third part, that is the third part of the flow chart. So what you need to do in case of abnormal colposcopy results. So the abnormal colposcopy can be due to CIN1, CIN2 or 3 or a CGIN. So in case of CIN1, you need to do a HPV testing in 12 months. In case the HPV is negative, then you need to recall her in 36 months. However, if the HPV is positive, then you have to do a cytology. So that is obvious. Always you need to remember that if the high risk HPV is positive, you have to do a cytology, and accordingly it will follow. That is the same thing as in part 1. Now, in case you have CIN2 or CIN3, then you have to provide some form of treatment. 2 and 3 cannot go without treatment. So 2 and 3, you have to provide some form of treatment, and then you need to call her for a recall, that is a test of cure in 6 months. So you will do a high risk HPV testing at 6 months. In case the high risk HPV is negative, then you recall her in 36 months. In case it is positive, then again go for cytology, and then if the cytology is also positive, then go for colposcopy, the same pathway as in part 1. Now coming to CGIN, CGIN also requires treatment, and you need to recall her in 6 months. It can be now after recalling in 6 months. That is, you need to do the test of cure in 6 months. That is the high risk HPV. So high risk HPV, in case it is positive, then you have to do the cytology, and accordingly you will follow the part 1 protocol. And in case it is negative, then you need to recall in 12 months. So please remember, in case it is negative, in case of CGIN, you need to recall in 12 months, not in 36 months. You need to recall in 12 months, and in case again it is negative, then only you can recall in 36 months. Otherwise, in all the other cases, in case the high risk HPV positive is high risk HPV is negative, you can straight away recall in 36 months. But it is not so in CGIN. In CGIN, if the first test of cure, that is HPV, is negative, still then you have to recall her in 12 months. Again, if the HPV is negative, then you can recall her in 36 months. So this is a very important difference. So please remember that. Okay. So please go through these flowcharts. These flowcharts are not so much complicated as they appear to. In case you are able to understand the way I explained it to you, in case you are able to understand the way I told you, then it will be a cakewalk for you. And these questions, these are very straightforward questions with no confusion whatsoever. Because in MRCOG, there are a number of questions where you have considerable confusion. What will be the answer? So one guideline mentions this, the other one mentions this. No one is actually sure. But NHS system, the system of flowcharts, these are very straightforward questions. So you should not miss out on this, okay, after seeing the video especially. So this is the answers which we have already discussed. Now let us come to cervical cancer in pregnancy. A 35-year-old woman is found to be 34 weeks pregnant when she is diagnosed with stage 1B1 cervical cancer. So what will be your most appropriate management? So she has 1B1 cervical cancer. So what is the treatment for 1B1 cervical cancer? That is surgery. Okay. So surgery is the treatment for 1B1 cervical cancer. So definitely she is already 34 weeks. So you will go for a classical cesarean section followed by surgery in the form of radical hysterectomy, pelvic lymphadenectomy, okay, because she is already 34 weeks pregnant. So this is again a very important flow chart which we need to remember for cervical cancer in pregnancy. So depending on the period of gestation and the stage, you need to manage a patient with cervical cancer in pregnancy. So in case she is 1A2 or 1B1, so in case she is less than 22 weeks of gestation, you can go for a pelvic lymphadenectomy. In case it is positive, that means she is already stage 3, then you should go for a termination of pregnancy. However, in case it is negative, then you can actually go for a simple trachelectomy, or you can actually delay the treatment after delivery. In case she is more than 22 weeks of gestation, then you can actually delay the treatment. You can actually wait because it's an early stage, or you can go for NACT. NACT will actually downstage the tumor while she is pregnant, and you will be able to do a surgery after delivery. Now, similarly for 1B2, if it is less than 22 weeks, you should go for a pelvic nodal dissection or a NACT. And in case she is more than 22 weeks of gestation, then you can go directly for NACT or delay the treatment. So you need to remember, you need to understand the basic fact that in case a person is more than 22 weeks and she has an early stage of cervical cancer, in such cases we can actually wait till her delivery, so that we are giving her a chance of fertility. Otherwise, if we just remove the entire thing or we go for concurrent chemo radiation, it will lead into she'll not be able to get pregnant. Maybe she'll not be able to get pregnant in the future once she gets this radiation. So it's better, in case she is diagnosed at a later gestation, that is greater than 22 weeks, you wait, or while waiting, you can give her neoadjuvant chemotherapy in the form of carboplatin and paclitaxel. Okay, so that is fully acceptable. However, for distant stages, that is for stage 3 onwards, you have to plan for a termination of pregnancy, or in case the woman is less than 22 weeks of gestation, then also you may need to plan for a termination of pregnancy. Now coming to the FIGO staging, many of the students had requested that FIGO staging is very complicated, and sometimes you get very easy questions from FIGO staging, EMQs from FIGO staging, where they have actually given you a case scenario and they have asked you to stage the disease. So FIGO staging of endometrial cancer is very important, and they are bound to ask you questions from here because this is the new staging which was introduced in 2023. So let us just go through the FIGO staging of endometrial cancer. So FIGO staging, they have divided it was earlier a very simplified staging. Now they have divided the entire thing into 4 stages. That is stage 1, stage 2, stage 3 and stage 4. And each stage they have now subdivided into 3 parts. Okay, so this is how you can remember. So stage 1 is divided into 3 parts, stage 2, 3 and stage 3 and stage 4. So coming to stage 1 means when it is confined to the organ. So confined to the uterine corpus and the ovary. And now again 1A is again divided into 3 parts. So if the disease is limited to the endometrium or it is non-aggressive histologic type, that is low grade endometrioid with an invasion of less than half of the myometrium, with no or focal lymphovascular space invasion or a good prognosis disease. So what is 1A1? 1A1 means it is limited only to the endometrium or to an endometrial polyp. 1A2 is involving less than half of the myometrium with no or focal LVSI. So remember, there is no LVSI and it is all non-aggressive variety. 1A3 is low-grade endometrioid carcinoma, which is limited to the uterus and the ovary. So these are the synchronous varieties, which is actually included in 1A3. 1B is invasion of half or more of the myometrium with no or focal LVSI, and 1C is it is an aggressive limited to the polyp or confined to the endometrium. So 1C is aggressive limited to the endometrium, and 1A1 is non-aggressive limited to the endometrial polyp or the endometrium. So this is how you need to keep on revising it so that it gets embedded in your mind. Otherwise, just revising it a day before the exam, it's very hard to remember. Okay, so just revise it with me, then it will be easier. Now coming to stage 2. So stage 2, what they have seen, in case the cervix is involved or there is LVSI or it is an aggressive type, that they have included in stage 2. So stage 2A is cervical stromal invasion, stage 2B is substantial LVSI of non-aggressive histological types, and stage 2C is aggressive histological type with any myometrial involvement, irrespective of it is less than 50%, more than 50%, it doesn't matter, but if it is an aggressive histological type. Now coming to 3A, in 3A, in case it is again divided into 2 types, 3A1 and 3A2. 3A1 is spread to the ovary or the fallopian tube except when the meeting the stage 1A3 criteria, and 3A2 is involvement of the uterine subserosa or spread through the uterine serosa. 3B is metastasis or direct spread to the vagina or the parametrium, and 3B2 is metastasis to the pelvic peritoneum. Remember, it is to the pelvic peritoneum only, and here 3B1 is metastasis to the vagina or the parametrium. Now coming to 3C, 3C1 is pelvic node, 3C2 is para-aortic node. So para-aortic nodes till where we consider up to the renal vessels. In case it goes beyond the renal vessels, then it is stage 4. So 3C1I is micrometastasis, 3C2I is macrometastasis. Now coming to stage 4. Stage 4A is invasion of the bladder mucosa or the intestinal or the bowel mucosa, and 4B is abdominal peritoneal metastasis beyond the pelvis. 4C is distant metastasis, that is to the intra-abdominal lymph nodes above the renal vessels, lungs, liver, brain or bone. So this is 4C. So 4C, 4 is entirely depending on the distant metastasis. So these are the various types. These are the various inclusions in this FIGO 2023. They have divided the histology into aggressive and non-aggressive type. They have divided LVSI as substantial or extensive, and lymph node also they have divided into macrometastasis, micrometastasis. Also, they have told in case you are able to do, in case it is feasible and available, then molecular classification is encouraged for all the endometrial cancer patients. So the most important thing which is asked in the SBA is how to differentiate between 1A3 and 3A1. So in case of 1A3, no more than superficial myometrial invasion is present, absence of substantial or extensive LVSI, absence of additional metastasis, and the ovarian tumor is unilateral, limited to the ovary without capsular invasion or rupture. That is, it is equivalent to PT1A. Now, how does the molecular staging affect the staging? In case you know the molecular classification, that in case it is polymutated, the tumor is actually downgraded. So in case the mutation is polymutation, regardless of the degree of LVSI, histological type, in case it is confined to the uterine corpus or with cervical extension, that is in case even it is stage 2, it will be downstage to stage 1A only because it is polymutated, which has an excellent prognosis. However, in case it is P53 abnormal endometrial cancer, and however it is still confined to the uterine corpus or with any type of myometrial invasion or cervical invasion, or irrespective of the LVSI or histologic type, it will be straight away upgraded to 2C. So even if it is 1A but it is P53 abnormal, then straight away, because you know that it's P53 abnormal, straight away the staging will be now 2C MP53. Okay, so this is the difference. This is the major, these are the major changes which you need to remember, and from which actually they are ask you questions in case of endometrial cancer. Now let us come to the management of endometrial cancer. So a 60-year-old woman underwent a TAH-BSO and was diagnosed with poorly differentiated endometrial cancer with more than 50% myometrial invasion. What will be the most appropriate management? Here the answer is both EBRT and brachytherapy. So it is a poorly differentiated endometrial cancer and it has more than 50% myometrial invasion. Okay, so let us look at the broad classification of how to manage in case of endometrial cancer. So this is in brief regarding the entire thing. This is a sum up and this is a table which will actually, because with the management many students have many queries regarding the management of endometrial cancer. So in 1A grade 1, just a hysterectomy BSO will suffice both in 1A grade 1 and grade 2. However, if it is grade 3, 1A grade 3 or 1B grade 1 or grade 2, here you have to do a lymph nodal dissection as well as you need to do a VBT. So this is very, very important. You need to do a lymph nodal dissection as well as a VBT. In 1B grade 3, however, if it is an aggressive histology, so this was as far as our question is concerned, that is poorly differentiated, that is grade 3, and it is 1B. Okay, so in such a case, if it is 1B grade 3, then you have to go both for a lymph node dissection. Yes, it has to be done from 1A grade 3 and 1AB onwards. You need to do a lymph nodal dissection. You cannot, you can only do away with lymph nodal dissection in stage 1A. But however, from 1B onwards, you have to do lymph nodal dissection. Please remember, these are all as per the earlier stage. The earlier stage which we used to follow, that is 1A is less than 50%, 1B is more than 50%, not the newer staging. This management is entirely based on the early staging that we follow. So in 1B grade 3 aggressive histology, you have to go for a lymph nodal dissection, and as an adjuvant, you can go for EBRT and brachytherapy. Stage 2 also, you can go for EBRT brachytherapy. However, if the lymph nodes come out to be positive, that is at a stage 3, then you have to go for a concurrent chemoradiation or a sequential chemoradiation, that is chemotherapy, EBRT, VBT. All three needs to be given. In case of stage 4, you can go for rebulking surgery, or you can go for chemotherapy in the form of NSCT followed by surgery, or a palliative RT or hormonal therapy. So these are the options in case of stage 4 disease. So please go through the management once. Now coming to staging in an ovarian cancer. So in ovarian cancer also you need to follow the same principle. That is, stage 1 is confined to the ovary or the fallopian tube. Stage 2 is pelvic extension. Stage 3 is again the lymph nodal involvement, and stage 4 is distant metastasis. So stage 1 is divided again into 3 types. Stage 1A is limited to one ovary. Stage 1B is limited to both the ovaries. Stage 1C is divided into 3 types. 1C1 is surgical spill, 1C2 is capsular rupture before surgery or tumor on the surface, 1C3 is malignant cells in the ascites. Now stage 2 is in case it is limited to the ovary and it has extended to the fallopian tube. So or the uterus. So extension or implant on the uterus or the fallopian tube or the ovaries, that is stage 2A. 2B is extension to other pelvic intraperitoneal tissues. 3A1 is positive retroperitoneal lymph nodes. 3A2 is microscopic extraperitoneal lymph node or peritoneal involvement, because we all know that ovarian cancer is actually a peritoneal disease. So in case the extrapelvic peritoneal involvement is microscopic, then it is 3A2. 3B is macroscopic involvement up to 2 centimeter, and 3C is the stage which we usually find. It is macroscopic peritoneal metastasis more than 2 centimeter in dimension. You should note that extension of the tumor to the capsule of the liver or the spleen without parenchymal involvement of other organ is 3C. Now coming to stage 4. In stage 4, in case it is stage 4A, it is pleural effusion with positive cytology. In stage 4B, it is parenchymal metastasis, that is parenchymal metastasis to the spleen or the liver or the inguinal nodes, that is any nodes which is outside the abdominal cavity, be it supraclavicular node, mediastinal nodes, cardiophrenic nodes, these are all 4B disease. Okay. Now, coming to the management of ovarian cancer. So we all know that for epithelial ovarian cancer, the management is either go for surgery followed by chemotherapy, or you go for NACT, that is neoadjuvant chemotherapy, followed by interval debulking surgery, followed by adjuvant chemotherapy. So that is in brief regarding the epithelial ovarian cancer. Now coming to dysgerminoma, that is the non-epithelial ovarian cancer, that is dysgerminoma, immature teratoma, York-Sac tumor. These are the three most common varieties. Please go through the tumor markers as well, because tumor markers are asked in the form of SBA. So in dysgerminoma, you can go for a fertility sparing surgery, because these are highly chemosensitive and radiosensitive tumors. So in stage 1A, you can go for a fertility sparing surgery with active surveillance. No need to go for any chemotherapy. 1B to 1C also you can go for active surveillance in case the patient is properly staged. In 2A to 4, you can go for full staging or debulking surgery with adjuvant chemotherapy. Immature teratoma, in case of 1A grade 1, you can go for a fertility sparing surgery or full staging surgery with active surveillance. Only in grade 1, you can go for active surveillance. However, in 1A grade 2 onwards, in case it is fully staged and negative postoperative tumor markers, you can go for active surveillance. But in case it is not fully staged, then you should go for a adjuvant chemotherapy. So please remember, for 1A grade 1, usually in immature teratoma, we omit chemotherapy. However, in dysgerminoma, in 1A, 1B, 1C, all the 3 stages, you can actually omit chemotherapy in the entire stage 1. Stage 1B to 1C, you have to give chemotherapy. Stage 2A to 4, you have to give chemotherapy. Again, York-Sac tumor. York-Sac tumor, in case it is fully staged and negative tumor markers, you can keep it on active surveillance. Please remember, York-Sac tumor is not as chemosensitive as immature teratoma or dysgerminoma, or particularly dysgerminoma. So in York-Sac tumor, always we advocate that yes, you can give chemotherapy in case she is not fully staged, or in case the tumor markers in the postoperative period are positive, then it is better to go for chemotherapy even in stage 1A. So please remember, in dysgerminoma, the entire stage 1, you can avoid chemotherapy. In immature teratoma, 1A grade 1, you can avoid chemotherapy. In York-Sac tumor, for all the stages almost, we need to give chemotherapy. Now coming to sex cord stromal tumors. So similarly for sex cord stromal tumors, in 1A, you can go for just surgery without chemotherapy. In 1C1, you can go for a fertility sparing surgery also in 1C1. In 1C2 to 3 onwards, you have to go for adjuvant chemo. So in granulosa cell stage 1A and 1C1, you can actually observe the patient and you can let go of chemotherapy. And in Sertoli Leydig cell tumor, you have to go for you can go for a fertility sparing surgery in stage 1A. However, in case the tumor is poorly differentiated or it has heterologous elements, which is a bad prognosis, then you may require to give adjuvant chemotherapy in such a case. In case she is more than 1A, so any tumor more than 1A, in case of Sertoli Leydig tumor, if it is staged more than 1A, then you have to go for adjuvant chemotherapy. Okay, so please remember the difference between Sertoli Leydig cell and granulosa cell tumor. In granulosa cell tumor, from 1C2 onwards, you have to give chemotherapy. In Sertoli Leydig cell tumor, any tumor more than 1A, you have to give chemotherapy. And also remember that in case it is poorly differentiated or has heterologous elements, then yes, you need to go for adjuvant chemotherapy. Okay. So this is all for today, and let me know in case you want me to cover any other topic on oncology. These are the most commonly asked doubts from the students, so that's why I covered these topics. So all the best and keep preparing, keep practicing and keep revising oncology. So this will help you excel in this module. Okay. So thank you so much. In case of any doubts, feel free to comment, and in case you have liked the video, please like and subscribe. Thank you so much.